Good morning. We welcome everyone today. We encourage you to continue to enter your organization name and which state you are from. My name is Gina Anderson, and I will be facilitating this session. And I have with me my team members, who are Carolyn Dutton and James Alexander, who will be supporting me through chat. And then I'm also excited to have Vicki Worth as our guest speaker today. As we get started, I have a couple of quick announcements. By attending all of the ECHO sessions, you will receive a certificate of completion. We ask if you're able to use your cameras that you would be willing to engage by using those cameras and turning them all on, and then through chat. You can help support each other on this call and verbally share during our case study. And this is going to follow our ECHO recommendations in collaborating with one another. Now, this is a Project ECHO disclaimer for you to reference that shares the data that is collected during these ECHO sessions. Now, before we begin, this slide will inform you how to connect with Telligen by adding us to your trusted list of email contacts and locating us at our website and social media avenues. As you receive this information, we challenge you to visualize and plan how will you use this presentation leading to impactful outcomes. We provide questions here for you to consider, and you'll receive these slides to further ponder them and build out your actionable process. This is an overview of the framework for the high-risk medication ECHO session we have lined up over the next several weeks. The outer ring is the 4 domains that affect your high-risk medication management system. The descriptors that fall within those domains are in the colored sections. These could be functioning well or where you may find your challenges. Now, the light gray ring next to the inner circle are areas we must address, implement action, and continuously monitor to ensure the domains function to their fullest potential. With this, we invite you to attend all of the ECHO sessions to learn more about each of these domains and to receive a certificate of completion. The high-risk medication ECHO series can be used to support the age-friendly health system. You have links on this slide to learn more and gain resources, but I do want to point out our goal is to improve the 4 M's with the residents and the patients that you care for. During each of these sessions, our focus will be on the medication aspect. With this, it includes having a monitoring system in place, making necessity decisions, and ensuring the medication does not interfere with what matters, mentation and mobility. Now, the objectives for this session are to describe the relationship between high-risk medication management and the potential impact on nursing homes, discover resources to support medication management processes, and recognize opportunities for collaboration, which may impact positive outcomes. Today, we are discussing the topic of regulatory requirements that impact the nursing homes. Now, when we consider high-risk medications, we are looking at medications that increase the risk for negative outcomes and adverse events. Medications such as antipsychotics, opioids, anticoagulants, and diabetics will fall under this list. We brought together this data to share the number of citations received in these tags across Telligen's region. Our hope is to give you this data to drive our thoughts on the impact to the nursing homes if processes are not functioning well. The processes is impacted by multiple systems and the people who work within that system. All of you are a part of this system. Collaborating to work together, no nursing home is exempt from potentially receiving a deficiency in multiple areas beyond what you see here. It takes a collaborative approach to support the system. Now, I am honored to introduce our guest speaker, Vicki Worth. Vicki started her health career as a dietary aide in high school back in 1993. After high school, she went on to receive a Bachelor of Science degree in Business Administration with a major in marketing. She worked in advertising for many years, then returned to the long-term care healthcare industry, where she worked as a CNA, LPN, RN, and DON. Vicki gained extensive experience in both management and clinical positions in skilled, intermediate, and dementia-specific care units. She joined the Department of Inspections and Appeals in 2014 as a long-term care surveyor, conducting recertification and complaint surveys throughout Iowa. Vicki was promoted within the Department of Inspections of Appeals to the Long-Term Care Bureau Chief position in August of 2020, where she oversees the surveyors who conduct the recertification and complaint surveys. So with that, Vicki, I'm excited to turn it over to you.
Thank you. So, hello. As Gina said, I'm from Iowa and I'm a long-term care bureau chief who oversees the regulatory survey process. I'm responsible for training surveyors as well as managing the enforcement process. I'm going to be speaking quickly as 10 minutes is not a lot of time to cover the regulatory group for pharmacy services, but I'm going to give it my best shot with a high-level overview. So FTAG 755 is the overall regulation that we cite when a provider fails to provide pharmaceutical services. Pharmaceutical services really is a broad category and it encompasses the entire process from the moment the order is received from the physician to the point medications are discontinued or destroyed. This includes the policies and procedures a provider develops around acquiring, receiving, storing, controlling, reconciling, dispensing, packaging, labeling, distributing, and administering medications. And it doesn't stop there. It also includes the monitoring of those medications, relaying medication-related information to the pertinent individuals like physicians and residents. But also there should be a process of identifying, evaluating, and addressing medication-related issues to prevent medication errors. Since the category is so broad, you can see why this is a highly cited regulatory category. Some of the issues that we see involve failures of providers to have strong policies and procedures in place to address all of those individual steps in the process. For example, a provider who fails to ensure a new resident had medications available in a timely manner, that would be cited here. The provision of pharmaceutical services is an integral part of the care provided to nursing home residents. The management of complex medication regimens is challenging and it requires diverse pharmaceutical services and formal mechanisms to safely handle and control medications. To maintain accurate and timely medication records and to minimize medication-related adverse consequences or events. The overall goal of pharmaceutical services system within a facility is to ensure the safe and effective use of medications. Preventable medication-related adverse consequences and events is a serious concern in nursing homes. The U.S. Department of Health and Human Services Office of the Inspector General issued a report in 2014 on adverse events in skilled nursing facilities that found 1 in 3 skilled residents experienced an adverse event or temporary harm event. 37% of these adverse events were related to medications, and 66% of all medication-related events were preventable. Medication-related adverse events include excessive bleeding due to anticoagulant use without adequate monitoring and acute hypoglycemia. Consequences of medication-related adverse events include a prolonged skilled stay, hospitalization, life-sustaining interventions, permanent harm, and death. The consultative services of a pharmacist can promote safe and effective medication use. A pharmacist, in collaboration with the facility staff, establishes, evaluates, and coordinates all aspects of the pharmaceutical services provided to all residents within a facility by all providers. A pharmacist can also help in the development of medication-related documentation procedures and can help guide the selection and use of medications in accordance with the authorized prescriber's orders, manufacturer specifications, characteristics of the resident population, and individual resident conditions. Next slide. So the intent of this requirement is that the facility prevents or minimizes adverse consequences related to medication therapy to the extent possible. FTAG 756 is where the pharmacist is to review the resident records looking for irregularities. The failures we see in this regulation many times are related to a lack of documentation to show the irregularities were conveyed to the physician, and a lack of documentation in the clinical record to reflect either action was taken or rationale for why it wasn't. Having strong procedures for these processes would make it easier for providers to quickly provide surveyors the evidence that they are on top of these monthly reviews. Next slide. The difference between 757 and 758 is specific to the type of medication being reviewed. If a surveyor were to determine that something like an antibiotic was ordered without proper labs, such as a culture and sensitivity to determine that it's the proper treatment, that's something potentially cited under 757. And if the medication is a psychotropic med, that is determined to be unnecessary, then the surveyor was cited under 758. The intent of these requirements is that each resident's entire drug medication regimen is managed and monitored to promote and maintain the resident's highest practical mental, physical, and psychosocial well-being. Any combination or combination of medications or the use of medication without adequate indications, in excessive dose, for an excessive duration, or without adequate monitoring may increase the risk of a broad range of adverse consequences such as medication interactions, depression, confusion, immobility, falls, hip fractures, and even death. As part of all medication management, it's important for the IDT team to implement non-pharmacological approaches designed to meet the individual needs of each resident. Educating facility staff and providers about the importance of implementing individualized non-pharmacological approaches to care prior to the use of medications may minimize the need for medications or reduce the dose and duration of those meds. Next slide. The indications for initiating, withdrawing, or withholding medications, as well as the use of non-pharmacological approaches, are determined by assessing the resident's underlying condition, their current signs, symptoms, expressions, and preferences and goals for treatment. This includes, where possible, the identification of any underlying causes, since a diagnosis alone may not warrant treatment with medication. Orders from multiple prescribers or providers can increase the resident's chances of receiving unnecessary medications. The facility's pharmacist is a valuable source of information about medications, and the attending physician plays a key leadership role in med management by developing, monitoring, and modifying the med regimen in conjunction with the resident, their families, and other professionals and direct care staff. That's the entire IDT team. When selecting medications and non-pharmacological approaches, members of the ID team participate in care process to identify, assess, address, advocate for, monitor, and communicate the resident's needs and changes in condition. The regulatory guidance is intended to help a surveyor determine the facility's medication management supports and if it promotes this. The resident's medical record documents and communicates to the entire team the basic elements of the care process and the resident's goals and preferences. It's important to note, while there may be isolated situations where pharmacological intervention is required first, these situations do not negate the obligation of the facility to develop and implement non-pharmacological interventions. Next slide. These two regulations are where med errors would be cited. If the error occurs while an observation is being conducted, then surveyors will cite FTAG 759. And if the medication being administered is considered a significant medication, then the error is cited at 760. A significant medication error means one which causes the resident discomfort or jeopardizes his or her health and safety. Significance may be subjective or relative depending on the individual situation and duration. For example, constipation that's unrelieved because an ordered laxative was omitted for one day results in a med error. It may cause a resident slight discomfort or perhaps no discomfort at all. However, if this omission leads to constipation that persists for greater than 3 days, the med error may be deemed significant since that constipation causes an obstruction or fecal impaction that can directly jeopardize that resident's health and safety. The relative significance of medication errors is a matter of professional judgment, and a surveyor follows 3 general guidelines in determining whether that medication error is significant or not. The first is resident condition. The resident's condition is an important factor to take into consideration. For example, a diuretic fluid pill erroneously administered to a dehydrated resident may have serious consequences, but if it's administered to a resident with normal fluid balance, it may not. If the resident's condition requires rigid control, such as strict intake and output measurement, daily weights, or monitoring of lab values, a single missed dose or a wrong dose can be highly significant. Next is the drug category. If the medication is from a category that usually requires the resident to be titrated to a specific blood level, a single medication error could alter that level and precipitate a recurrence of symptoms or toxicity. This is a single medication error could alter that level and precipitate a recurrence of symptoms or toxicity. This is especially important with a medication that has a narrow therapeutic index, NTI. Examples of medications with NTI include Dilantin, Tegretol, warfarin, Lanoxin, and other like meds. And then frequency of error. If an error is occurring repeatedly, there may be more reason to classify the error as significant. For example, if a resident's medication was omitted several times, it may be appropriate, depending on consideration of the resident condition and medication category, to classify that error as significant. And this is my high-level, very quick summary and introduction into the nursing home regulatory group of pharmacy services. Thank you, Gina.
Thank you, Vicki. That was all excellent information and very good to hear how the impact is in some of those examples that you shared. We appreciate your time in sharing that information. So I have here a case study for all of us to look at, and I'm going to be reading through this, briefly summarizing it, and then I want you as participants to speak up and share what your thoughts are. So I'm going to take a moment here to read this through, and then we'll go from there. So this case study was taken from an actual survey results that was conducted over the course of last year. So just wanted to share that piece with you. So we have Sally, who is a resident in a skilled nursing facility. She has an undated diagnosis of Alzheimer's disease with behavioral disturbances and noted she has severe cognitive impairment. There was a medication regimen review dated in February, which documents the pharmacy recommended reducing the antipsychotic medication from 25 milligrams every morning and 50 milligrams every evening to 25 milligrams one tablet twice daily. The prescribing physician approved the dose reduction. There was no documentation that this reduction was implemented prior to March. The physician progress note dated in March documents to continue Sally's antipsychotic medication with no reduction. In August, the pharmacy again recommends reducing the antipsychotic to 25 milligrams, one tablet twice daily. The physician signed the reduction form and marked the box for patient has a good response to treatment and requires the current dose for condition stability. Dose reduction is contraindicated because benefits outweigh risks for the patient, and a reduction is likely to impair the resident's function and/or cause psychiatric instability. During the survey process performed in September, this facility was cited for a Level D deficiency tag F758 for failure to complete psychological medication assessments, complete the abnormal involuntary movement scales or AIMS test, and to provide a rationale for gradual dose reduction refusals. Sally has only one completed psychological medication assessment in AIMS dated in July recorded in the chart. The infection preventionist shares that this does not follow policy. These assessments should be completed upon admission for any increased dosages, which had occurred a couple times during Sally's stay, and quarterly. A registered nurse stated that Sally's antipsychotic medication is for combative behaviors during care, yelling out, and resisting care. The nurse confirmed that the physician did not document a clinical rationale for declining the resident's dose reductions in February and August. So with that, we can see that we have Sally, who's on an antipsychotic medication, and the pharmacist 2 times within the year recommended reducing it, which in the first case did not happen, even though the physician had agreed, but later disagreed. And then in August, again, it was declined as a dose reduction. And then during the survey process, they identified some of the assessments have not been completed per the policy. So with all of that information, I would love to ask the audience today to verbally speak up, or you can share in chat. What are your first thoughts that stand out to you in this, or what do you hear here that could be something that is not good, but then again, maybe a recommendation that you have? So I'm going to start with verbal sharing. So if anybody would like to unmute and open up what your thoughts are, we would appreciate that.
Well, I think I'm going to go ahead and jump in. I'm Keith Swanson. I'm a pharmacist and oftentimes teach in a lot of dementia courses, things like that. I go back to, one of the many things that happen in here. Some of it is just basically the documentation stream that happens. That first recommendation for a dosage reduction should have actually been used to substantiate a new order. And sometimes it falls upon the staff at the facility itself to basically start tracking those, following up on those, writing up a dosage change for this physician's signature, And some of the facilities I've seen actually would use that that consultant report with the physician agreeing to change a dose as actual an order, and it should have been implemented at that point. It's at some point the system broke down and just simply didn't get that dosage change processed.
That's great information, Keith. Thank you so much for taking your time to share and to be with us today. Does anybody else have anything verbally to share during this time?
Hi, good morning. Yeah, thank you so much. I think just in general, it seems like there's just very poor communication all the way around. And I was also just a little bit curious about the documentation of behaviors, like the lack of documentation for the follow-up and the reason for returning to 25 milligrams. So I just think documentation is so important, and it seems like there are some opportunities for improvement around that here.
That's a great point to share, is that communication piece first. That's a big foundation in all of this work, collaborating with each other and making sure, everybody's communicating with each other in order to get new orders implemented, and to tell the physician exactly what are those behaviors. And that's documentation is an excellent point to make. If we're documenting those behaviors, we can certainly be able to look at what all those aspects are when we're making these decisions. So Carolyn, I'm going to go to you for a minute, who's monitoring chat. Do you see anything that's posted in chat that you would like to share?
Yeah, Gina, there's quite a few comments here. We have one that says it appears the physician approved the decrease in dose in February, but the decrease was not documented. And I've also got lack of follow through with the medication change. Pharmacist recommendation has not been taken multiple times, and lack of nursing not ensuring orders are completed and implemented as soon as they are given. I've also got someone that's recommending doing a root cause analysis to see what's going on with this change and why it was missed. So those are some of the comments we've got coming up here.
Thank you, Carolyn. Those are great comments, and I love all of them, but the root cause analysis really stands out. What is the root cause for these behaviors? What is the root cause for not documenting or not having this great communication effort? So there's a lot of different avenues you can go with that root cause analysis. Anybody else that would like to share on what their thoughts are with this case study?
Well, listening to the silence, I'm going to go ahead and jump back in. This is Keith Swanson again. And as a pharmacist, I always go back to, even the original starting of the medication. Clinical evidence really suggests that antipsychotics really don't do anything better than the placebo in some of the trials that we've seen. It's got controlling behaviors. And that's where the documentation of really why the medication would start. Was it just the person was combative, which can indicate some maybe agitation from a urinary tract infection or untreated arthritis or something like that? Or really was it true psychotic behaviors such as delusions or persecution complexes that might actually respond to it? There's some data that suggests a low dose antipsychotic really doesn't do anything more than just an antihistamine like diphenhydramine, Benadryl, or hydroxyzine Atarax might do. It's really just a sedative, and we might be better using other agents. Oftentimes, if it really is agitation or anxiety, using an antidepressant or an agent such as buspirone, which really targets that kind of anxiety, might be a better choice.
Those are great points, Keith. And, I love the fact that you brought out, there's specific medicines that might help specific behaviors, but looking at the behaviors, it's daring care, yelling out, and resisting care. So it's, you never know what, again, back to those causes. Do our people who are supporting the care understand how to handle a person with dementia, Alzheimer's disease, or these dementia-related diagnoses? So those are great points to pull out on any of this.
Yeah, and I'm going to jump in just something you said there, that oftentimes we look and see, is a person even receiving something like acetaminophen Tylenol for arthritis? Is it that they're in pain while that care is being given, where if we control that pain, they might not have the agitation?
Absolutely. So what's unspoken here from that person as well? Great points. With that, I'm going to see Carolyn. Is there anything else that's in chat?
Yeah, Gina, here is one that I think is pretty important. One person says, I think it's helpful to develop internal processes that the IDT can use to explore behavioral reactions and address them before the doctor is involved. So that may be important as well.
Absolutely. Kind of makes me think of all those alternative approaches that we can consider. So before we move on to the next slide, I'm going to give another shout out to anybody who would like to share verbally that's participating today.
Yeah, good morning again. I just want to say how helpful this is to talk through this. I also agree with Keith and just thinking about some of the resident conditions not being factored in. And one of the things that we're looking at is just what type of education is being done for our nursing assistants to help them support people living with dementia so that they can provide care without invoking these types of responses. So this is really helpful. Thank you.
Thank you. Well, I think with that, we're going to go ahead and move on to the next slide. I have a great resource to help support you with all of this regulation talk that we've been doing. So we've created for you this regulation map to help you with your navigation of the many regulations that are tied to the medication management system. We know time is limited and every provider is very busy. So we pulled together the direct links and topics for your review to become familiar with the processes that are expected to be carried out. Now, this just isn't for nursing home knowledge. We encourage all those beyond the nursing home team, the medical directors, prescribing clinicians, pharmacy consultants, hospitalists, discharge planners, and others who have a part in the nursing homes or the elder care coordination of that medication management. We encourage you to take note on how you can support the outcomes that impact this system. Now, this is a continued list of that regulation map. There are a lot of parts that are tied into this high-risk medication management topic, and this is not an exhausted list. At the top, the dark blue boxes, you will find the regulation code, and that is linked to the online federal regulation, which provides more of an overview for those regulated processes. Now, the information in the lighter blue, you will find several topics under each of those codes, but also the page number to the state operations manual for a quick find. We added this because the state operation manual provides all the details, the regulation, process details, what surveyors will be assessing, and in some cases share examples. Also, the F tags are listed to have that as reference so that you know if this topic is out of compliance, this may be the deficiency tag that is received. Now, quality improvement involves a combined effort among healthcare providers to mitigate problems in the healthcare system. The linked article familiarizes healthcare professionals with how to become to begin a quality improvement project, which includes 3 main steps: setting aims or goals to the focus improvement, choosing a balanced set of measures to determine if improvement occurs, and testing new ideas to change the current process. So using the quality improvement methodology, we encourage you to take action by exploring the regulation to be informed of the required elements and impact in long-term care, whether it be an internal or external role of the nursing home facility. By sharing your vision on improving the medication management system with everyone who has a part in this. By collaborating with external partners and invite others to the remaining ECHO series so you are all on the same page in this effort. And last, bring your high-risk medication management program to the quality assessment and assurance, the QAA meetings. Discuss the data and opportunities to improve on. We have this final poll questions for you to respond to as we close out our last few slides. Please take just a moment to complete this so that you can learn, or we can learn from you on how we are doing during these sessions. Your responses will remain confidential and your feedback is always appreciated. Here's a listing of our upcoming ECHO sessions and the dates, the topics within each of those sessions. Now, once you register, you should have received a Zoom invite for all of these sessions. If you attend all 7 sessions in this series, a certificate of completion will be sent to you. And we encourage you to please share this information with others in your network. Telegen QI Connect is contracted by CMS, and all of our support is at no cost. For those healthcare providers in the states of Iowa, Oklahoma, Illinois, and Colorado who partner with us, you will gain exclusive access to our quality improvement initiative, as well as our secure portal. The links to accessing our portal are on this slide. If you are unsure if you're a partner of Telegen QI Connect, please reach out to one of us here at Telegen. Or in your registration, you may have indicated you would like to enroll, or you will be getting a follow-up response from us. Here is how you can reach out to us if you need resources, tools, or have questions. We're happy to help assist you. And if you have not done so, please fill out that poll. We'll remain on the webinar for an additional minute. But thank you so much for attending and participating in this high-risk medication management improvement effort, and we hope to see you at the next session. Thank you so much.